Good afternoon to all. Today, I would like to thank Dr. Plexus at the onset for inviting me to give a brief introduction on what is precision oncology and what role it's going to play in our upcoming treatment in oncology, especially in oncology, but also I feel it will affect other subspecialties such as pediatrics, genetics, and also pharmacogenetics. That is an area of research where it may have a long-lasting impact.
Thank you so much, sir. Sir, I would just like to introduce you. Sorry.
Sure. Shall we cut?
No problem. I'll start.
Yeah.
So, welcome to this brand new episode of MasterSeries session with our experts. And as Dr. Nikhil mentioned, we'll be talking about a very modern and leading discussion here, which is about precision medicine in oncology. For this, we have with us Dr. Nikhil Krishna Haridas. Welcome, sir. He is an assistant professor and consultant at the Department of Medical Oncology and Hematology at the Division Stem Cell Transplant at Amrita Institute of Medical Sciences in Kochi. He is a member of the European Society of Medical Oncology and the American Society of Clinical Oncology as well. His areas of interest include stem cells and other cellular therapies, gastrointestinal oncology, etc. And he has performed over 20 allogenic stem cell transplants, including haplotransplants and stem cell transplants, and has several publications to his credit. Absolute pleasure to have you with us here, sir. Please begin.
Thank you for the introduction. Now I'll proceed directly to what is precision medicine. Right now, the agreed upon definition for precision medicine, which is also known as personalized medicine or personalized genomics or genomic medicine, would be an application of a patient-specific profile, which incorporates the genetic and the genomic data as well as the clinical, what you call the phenotypic data, and the environmental factors exposed to the patient to assess an individual risk for a particular disease and tailor prevention and disease management strategies. Now, what are the potential benefits of the precision medicine? Now, what basically we mean by precision medicine is incorporating a lot of a genomic, or in fact, if you want to make it a much more wider scope of understanding, epigenetics, environmental modifiers, etc. All these are incorporated and studied for a particular person, whether he is a patient or even a normal person. And all these have a benefit of probably improving medical decision making in case of a diagnosed disease. For example, any cancers like a non-small cell lung cancer. It helps in delivery of appropriate therapies, which are specifically tailored to the patient's genotypes or the genetic sequence, rather than what it is for a general population. Optimization in some normal people or even in patients with particular disease, there can be optimization of a disease prevention strategy. There is a concept called chemoprophylaxis among medical oncologists, and there is also lifestyle changes, which always have a lifestyle changes and behavior modification will have an impact. And as I already mentioned, pharmacopreventive measures, etc. And also, the precision oncology may help us avoid medications which may be lower in efficiency. It may help us predict the response, or rather the lack of benefit of certain drugs and molecules, and hence help us avoid those medications. Also, it reduces the exposure to medications that have a potential for greater toxicity, while resulting lower incidence of treatment-related side effects and complications. An example of this, which we are doing in our system for certain patients, there are some chemotherapeutic drugs which there may be an germline or an inborn mutations present, which lead to increased drug levels. So we will be able to predict that, and those patients give a lower drug levels if you are able to test for that. There's something called DPD mutations, which we analyze in oncology to look for toxicity for a medication called 5-fluorouracil. Now, what are the current limitations? I will expand on it later at the end of, what are the main components of an precision oncology. Now, current limitations that implementing and detailed genomic profiling remains a challenge in a clinical practice. You really, a lot of us don't know what exactly test to select for a patient in whom, some of the disease they have a particular uh, what is it, genotypes or genomes which are abnormal, and you can test for them, but there are some other disease where we don't know. And what do you order? You order for a complete genomic expression or a complete evaluation of the exomes, etc. And currently in India, as it stands, there is an high cost in the testing for a complete genomic expression. And also there is, with the data we're getting through all this, there's a lack of reliable predictive biomarkers for most conditions. That means the result we get, we really don't know whether a lot of these mutations or variant genetic variants are having any prognostic indication, or do they have any therapeutic indications or alternatives. Now, of course, as among us, the lack of a detailed genetic, both molecular related and genetic related knowledge base among us clinicians regarding both genetics, risk prediction, and the use of such extensive precision diagnostic tools. Now, coming to when we talk about precision oncology, a lot of it is or personalized oncology. A lot of it is dependent on the investigative methods or the genomic assays used to get the information regarding a particular disease or a particular tumor. Now, that's why precision diagnostics remain a major, backbone in management of in personalized medicine. Now, previously we do by techniques such as DNA or RNA polymerase chain reaction, that is the PCRs. We usually either look at single gene assay. Okay, that had been the mainstay for quite a while, at least from the 2000s to the 2010s. Single gene assay had been a standard of care for a lot of diseases. Common methods, as I already mentioned, include application of DNA, RNA by polymerase chain reaction. There is also fluorescent in situ hybridization, which is employed in molecular oncology. Fragment analysis using electrophoresis, restriction enzyme digestion, hybridization, as I already mentioned, with sequence-specific tools. And of course, the classic analysis of a genome variant, that is the Sanger sequencing or the Pyro sequencing, etc., was also used. Sanger and all that more or less is time taken. In the current assay, we look the advantage of running a single gene assay, that a particular gene, example, EGFR, or looking for BCR-ABL, or we are doing a FISH test for the 922, that is the Philadelphia chromosome seen in a chronic myeloid leukemia. These tests are very, they have a fast turnaround time. They are low cost because they have already probes and probes, etc., which are designed to detect these particular mutations when we expect them in a disease. And there's a lower complexity in developing, running, and interpreting the test, which is very important even now in India, where a lot of the advanced this molecular testing still remains out of reach of common man. And since each gene is evaluated separately for a single gene assay, these assays have to be customized to meet the need of the clinical context. For example, in case of patients with an CML, which is a classic example, we have the BCR-ABL translocation, and this can be detected. The single gene assay can be designed to be extremely sensitive and even give a quantitative value. And they are generally right now in India standardized across the laboratory, and this is used to both help diagnose and monitor the response to treatment. Now, also we can carefully, design some single gene assays to overcome some issues which happens with analyzing a complete genome, like using the next generation sequence or advanced molecular assays like next gen sequencing. This examples for this classically seen in acute myeloid leukemia, where there is a, the next gen sequencing is not sensitive in detecting something called FLT3 internal tandem duplication. So the duplication is not a deletion or a mutation, it's a duplication. So this is what gets missed out, FLT3 ITD, and that can be detected by a single gene assay. Now, as I already mentioned, it continues to be useful in clinical context in which we need just information about the limited number of genes. Even in certain assays for lung and all, previously EGFR and the EGFR mutation in non-small cell lung cancers, and all they were detected using a single gene assay. Now coming to NGS, or the next generation sequence. Now this is becoming the approach of choice for a lot of diseases. As I told you, more and more mutations and more relevant, targetable, molecular variants are being detected. It is not possible to keep doing multiple single gene assay. The advantage of single gene assay being the cost that definitely goes up as you involve a multiple panel. In this particular setting, next generation sequencing becomes increasingly an attractive approach. I will be just giving some headings under what compromise in next generation sequencing, because next generation sequencing has made personalized oncology or personalized precision medicine a reality for us, and we are able to practice, if not for all patients, for some of the patients. Now, the resources associated with designing, optimizing, validating, and running several single gene tests becomes prohibitively expensive when, as I told you, when the number of genes we need to analyze for a particular disease goes up. So the classic example right now is non-small cell lung cancer. We have multiple mutations, EGFR, we have mutations within EGFR. We have 4 exons we look at, and we look at multiple base variations. We look for deletions. There are also what is known as anaplastic lymphokinase mutations, ROS1, MET, RET. So all these mutations, it is not possible to do in single gene assay, and the next gen sequencing NGS would offer us an advantage over a single gene method in this case, because it is more sensitive than many single gene methodology, and also compared to some methods such as PCR, it may offer better sensitivity. But again, a major limitation is maybe we cannot do the entire genome sequencing. We can select the panel or the regions which we want to be analyzed, and even NGS can help us find out multiple genes at a single time. And also the advantage now with the next gen sequencing is that previously what was the what you call the turnaround time for a report to come, day by day it is coming, it is becoming lesser and lesser. Previously what used to take 1 month is taking now 2 weeks, 15 working days. Now, what is a gene panel versus unbiased genomic and transcriptome analysis? Genomic and transcriptome analysis refers to the analysis of the entire exome, that is a protein coding part of the gene, or the entire transcriptomes. And this is not practical. So that is why we focus on gene panel. If we are going to do even a comprehensive gene panel, which the commonest oncogenes and the mutations which are commonly encountered in multiple cancers all pulled together, they may have only 200 or 300 genes in these panels. You're not going to be testing for each and everything, because thousands of mutations may be there which we don't know the significance for. So advantage of doing a whole genome sequencing is only to detect essentially some rare genomic alterations or novel genomic alteration. It is a time-taking practice. It is very expensive, and it cannot reach sufficient depth to detect some low-level alterations in a sample which contains both normal cells and tumor cells. And also, as I mentioned already, you will get too much of data when you do such a thing. We don't know the value of a lot of the things in this data, because next-gen sequencing will give you a lot of data which is compared with some historic or previously based tumor variations and the evidence based on previous old studies. Of course, these information banks and informatics keep updating based on the system. And at currently, you get so much data, you really don't know what to do. We may not be able to analyze it. A geneticist may not be also, a genomist also may not be able to sit down and analyze and point out what could be the flaws with this. For example, one of the classic examples of patient having multiple whole genomic study done in non-small cell lung cancers have detected close to 888, and in non-smokers, and around 15,000, more than 15,000 mutations in the smoking patient. And we really don't, as I mentioned, all these vast majority are not clinically actionable. Maybe we may have close to, both for prognosis and targeting, we may around have 200 to 300 genes in all the cancers combined as of now. Now, in absence of comparison between tumor and normal DNA, distinguishing a somatic, that is, mutation from a germline, that is in birth polymorphism, it adds further complexity in interpreting it. So that's what most of the next-gen sequencing right now is panel-based rather than gene panel-based, rather than doing it for the entire genome. Now, WS stands for the whole exome sequencing. It's unbiased approach also, which has found some utility in, especially in research setting. Here, the sequencing is done to 1.5% of the genome, that is basically the exons. And this also generates a lot of bioinformatic data, vast majority of which we really do not have the clinical implication for, and we don't know how to proceed for it. Exome sequencing will also fail to detect some very specific pathogenic variants such as structural rearrangement, as duplications, then the intronic breakpoints, etc. And while the input and the DNA quality, that is from the sample, the DNA quality requirement is lower for exome sequencing than a whole genome sequencing. The drawback of this is that the depth of sequencing, that how much there is a particular depth refers to the particular number of times the cycle is run and how much we need sensitivity we need to detect a mutation. It is much lower than those are obtained by targeted panel. So most of the times we are preferring to go with targeted assay rather than a whole exome sequencing, or for that, of course, whole genome sequencing is impractical in the current practice. Now, the other format we are doing is focusing on the RNA. A lot of the newer next-gen sequencing panel are sequencing the RNA transcript, which include mitochondrial RNA and the small RNAs. The RNA sequencing data provides a snapshot of the gene expression panel. It's a reasonable alternative to the data obtained by a gene expression profiling, complete gene expression profiling. It is able to detect gene fusions also, which is not seen in the classic NGS when you're looking for exon sequencing. It will also provide the information about non-coding RNA. Coming to non-coding RNA in oncology, we really don't know the whether it has any diagnostic or a prognostic application as well. But again, the negative drawback of all this next-gen sequencing, RNA sequencing, is that we get a lot of complex data which we won't know how to interpret, and hence this is also not routinely performed by clinical labs. And to finish it, to say a sentence, most of these laboratories use targeted sequencing. For example, if you have a patient with the acute leukemia, there is a set of maybe 50-60 genes they look for to help in the risk stratification. Similarly, for non-small cell lung cancer, you will have maybe you have some panels which cost very less, as much as lesser than even 10,000 rupees, targeting only 15 of the targetable mutations, which also has a practical issue. In addition to have a lower sequencing cost and a faster turnaround time, this approach provides a much higher coverage of the genomic regions of interest, thereby enabling the detection of lower level alteration, which is an essential capability required for somatic mutation testing, that is the errors in mutation which led to the tumorogenesis rather than the genetic errors. And also this dramatically decreases the complexity of the data generated. As I already mentioned, the data generated is too much if you go for a whole exome sequencing. It reduces the time also and the effort also associated with the interpretation. Now, by focusing on these molecular alterations, which are clinically actionable, this reduces the risk of actionable data being overshadowed by the other fluff or the extra deluge of data which comes without any clinical benefit. And one word finally, these panels are generally designed. Different genetic companies develop these panels with capabilities to meet various clinical needs. Solid tumor panels, as I already mentioned, run with very small amount of nucleic acid, and you can, a small biopsy specimen or small aspirate specimen may be enough. In patients in whom we are not able to do an biopsy, solid, we are not able to get a solid tissue, the cell-free DNA which is circulating from the tumor in the blood can be used with sufficient sensitivity to detect the molecular alterations. Okay. Only principal drawback of target gene panel is that we need to know the beforehand what molecular alterations we are expecting. In fact, in most cases right now as it stands, we keep updating, as I mentioned, the data available, and we don't know whether the current novel alterations have any value. And as I mentioned, there'll be updating of the targeted panels as new clinically actionable molecular analysis emerge. Now coming to application of molecular oncology testing, this is a little more practical with the examples of what it has been the current form. Obviously for diagnosis, as I already mentioned, CML remains a favorite. BCR-ABL, the built-up chromosome, the BCR-ABL transcript copies. It can give both qualitative and quantitative analysis. This as it helps assist us in rendering a diagnosis, and also the pathological free features which are equivocal. In case pathological free features are equivocal, doing a next-gen sequencing or molecular diagnostic may help differentiate the tumor. This is commonly used in case of central nervous system tumors like gliomas and astrocytomas, and also for various sarcomas where pathological features alone may not be enough. Immunohistochemistry may not be enough to differentiate the data. One caution always when we are looking at data from molecular data from a NGS is that it should be correlated with other clinico-pathological data which we are seeing. Now, for example, when we see a patient with myelodysplastic syndrome, where there's a lot of mutations present in the peripheral blood and the marrow, these mutations may also be seen in normal healthy individuals with something which is called CHIP or clonal hematopoiesis or indeterminate potential. So this, you may be assigning an pathology or a disease to a person who is also normal, and in a patient whom you're suspecting a disease, the mutation which you're assigning as a part of the what you are suspecting may also, it might be due to a genetic mutation rather. Now again, as I mentioned, diagnosis, it also helps in prognosis. Molecular alterations found in the neoplastic cell frequently correlate with various prognostic indices. For example, in a glioma patient, when we find IDH1 mutation, they generally perform more favorably than those who have a wild type IDH. And also these prognostic associations can be used in counseling the patient, and there's also therapeutic implications in certain cases, and hence some of these mutations are included into standard right now. Even now mutation included under classification of central nervous system, for example, as I mentioned, IDH1 mutation. Similarly, as I already mentioned, in acute myeloid leukemia, we have mutations in multiple genes such as ASXL1, CK, TP53, NP1. They all have a prognostic markers. In fact, it helps take decision regarding the upfront treatment and also the need and the timing of stem cell transplantations because of this targeted panel gene assays. Now, of course, therapy, there's a major role in therapy because it identifies some oncogenic alterations which can be targeted either by small molecule inhibitors like tyrosine kinase inhibitors or monoclonal antibodies, okay, which are designed against them. One classic example was the detection of a BRAF mutation, B600 mutation. It may occur in 30% of the melanoma patients. And in these patients, immunotherapy is not the standard of care. Giving a BRAF inhibitor, MEK inhibitor like dabrafenib, trametinib, or vemurafenib, these are more efficacious in treating the melanoma rather than the conventional immunotherapy that we use. And of course, other molecular alterations in therapy helps predict resistance to therapy. For example, in colorectal cancer, if a patient has a KRAS and RAS mutation, in a metastatic disease. It indicates a primary resistance to anti-EGFR monoclonal antibodies. We use cetuximab and tumimab in our practice. So when I see this mutation, I will not use these molecules on the patient. I would select another molecule. Now, molecular findings frequently also guide the use of FDA-approved therapies. Outside of a classic, approved of off-label indications also, we can use them. Especially this is seen in patients who are multiply treated in practical use. We get based on information. Let's say a patient is a melanoma patient. In them, if they've been treated with, if they look for there's a KIT mutation, we can treat them with a TKA, the tyrosine kinase inhibitor colimatrib used in CML, and they may have a good response compared to giving conventional chemotherapy. Now, again, as I mentioned, targeted therapies are used in an iterative fashion that is based both on the alterations identified and those acquired during treatment. Now, even during treatment, in mid-treatment, doing an targeted gene panel helps identify secondary resistance or mutations developed to treatment. For example, patients who are initially sensitive to tyrosine kinase inhibitor in a lung cancer, later on, if the disease is progressing, looking for an T790M mutation in the EGFR, it helps identify the mutation and helps us change the treatment and hence give the patients a better quality of life and also prolong their survival. Another class of treatment for which molecular results are informative are again right now the in thing, that is the immunotherapy or immune checkpoint inhibitors. The tumor mutation burden, which is expressed, tumor mutation burden, which is expressed in the number of mutations per this thing. It can help, select patients tissue agnostic indication for using immunotherapy. Similarly, macrosatellite instability, etc., helps select the patients who are fit for immunotherapy. And also, unnecessarily, we need not treat the patient who have a low tumor mutation burden. There's no need to recommend such expensive therapies. It will be less efficacious. Now, coming to trials, so the precision oncology has also changed the way we do, and trials for drugs, for treatment. This is because the molecular results are being used to screen patients for molecular alterations. So various clinical trials for various particular cancer types with specific molecular alterations or trials with patients with advanced cancers who have a particular targetable molecular alteration in spite of the cancer type. You can segregate them or you can do them together. You can analyze them together. I'll be coming to that a little bit in detail because it's a commonly used terms now about the trials designs. Okay. And finally, precision diagnostics enabling clinical trials. We have basically in this era of precision medicine, we have two major types of trials. One is the umbrella trial, where a patient with the particular tumor type is subject to genome sequencing and is assigned multiple therapies which target the specific driver abnormality identified in each tumor. That is, for example, a very classic example again will be a lung patient. Vishna EGFR exon 19 mutation, he'll be assigned to one particular therapy. A patient having an exon 21 mutation will be assigned another therapy. Patient with exon 20 mutation, another therapy. Cross a different therapy. All this can be done in the same trial. And this paradigm maximizes the opportunity of patient to receive and benefit from precision therapies based on the identification by NGS of oncogenic drivers. Okay. I'll come to examples of umbrella trials. So this is what I meant by, now this is an umbrella trial with no controls and this is an umbrella trial with a control arm. So the NGS will help you, find different targets. This target can be for EGFR, this target can be for an ALK, this target can be for a MET or RET fusion gene. And if you are, and specific targeted therapies can be given. Now, various umbrella trials are there for various diseases. As you can see, A lot of them are for small cell, non-small cell lung cancers, and it is called battle trial, battle 1, battle 2, lung map. You can see most of the screening platforms are NGS. This is one of the older umbrella trials called I-SPY 2 in breast cancer. Here conventional screening platforms were used, and biomarkers were basically immunohistochemistry and some few genomic sequence based on a mamma print test. And treatment were all various treatments were given. As you can see, different mutations were targeted with different treatments. Yes. These are also the name of some classic. As you can see, most of the trials are done on small cell lung cancer, non-small cell lung cancers, and breast. Now, what is basket trial? It is the exact opposite of the umbrella trial. You have basically multiple tumor types or phenotype tumors with different histopathological classifications are treated with one specific drug targeting a common group or a single type of oncogenic driver alteration or mutation. And this approach is complementary to the umbrella trial approach, and it seeks to determine whether a targeted therapy has a benefit across diverse tumor types which share a targetable molecular aberration. Okay. So this is what we mean by basket trial. Patients with multiple diseases. This can be a breast, this can be colon, this can be lung. They have a common mutation. Let us say it is HER2. Okay, that is a human epidermal growth factor. They're all given the same medicine, anti-HER2, some therapy is given, and then the reports are interpreted. So these are few of the basket trials. V-basket trial was for solid tumors and multiple myeloma, assessing BRAF V600 mutation, and the target therapy was given. Single therapy was given. Similarly, we had a basket trial called CUSTOM for NSCLC. Again, multiple mutations, a group of mutation commonly seen in lung cancers were all targeted, and specific treatment was given for the same. And NCI NMATCH is a huge trial. It's accruing a lot of patients in multiple multiple tumor types, and they're using NGS, and they have detected close to 143 gene variations. Now these are all about trial, target, treatment. Now coming to disease monitoring, as mentioned already, a lot of the next gen sequencing and the molecular analysis help in monitoring response after treatment. Certain diseases such as CML, there is a prefixed response based on the quantitative BCR-ABL testing, or by which help in predicting favorable outcome in patients who receive what is known as a major molecular response, which is a 3-log reduction in BCR-ABL values. They generally have a good outcome compared to patients in whom you have greater than 3-log. I mean, the reduction is not present. Now, again, in between treatment also, they help detect secondary mutations we develop to treatment. NGS can be used to identify whether imaginary resistance are developed. Similarly, it can also be used in monitoring what is called as measurable residual disease, which is commonly used in hematological malignancies such as AML and ALL. Previously, this MRD was measured using flow cytometry, looking for the blast cells. And now I think in the future, now it is currently little prohibitive for our practical use, but in future, an MRD, molecular MRD based on NGS panel, may be the standard of care. A lot of the current clinical trials are using a molecular MRD in AML, ALL. Now, peripheral blood of patients with solid tumors also have been increased. For example, you may not be able to go in and get a biopsy from a patient in whom disease has progressed. Let us say it's a lung cancer patient. The disease, it may not be easily biopsiable, or there are a lot of morbidities associated with biopsy. In that case, a peripheral blood sample looking for the cell-free DNA or a circulating tumor cells can be used. And patients on treatment, as I already mentioned, can be monitored both for recurrence and acquiring resistant mutations. For example, in lung cancer, patients who acquire a T790M mutation in the EGFR. And the cell-free DNA not only offers a non-invasive alternative to detecting the resistant mechanism, but this may also mitigate the sampling challenges which occur in solid tumors due to tumor heterogeneity. The area you sample may have a particular mutation, a different area may have another mutation. That is eliminated by using cell-free DNA, because all the tumor DNA will be present in the peripheral blood in especially advanced disease. Now, of course, the molecular oncology and the precision oncology, precision diagnostics help us in detecting patients who have a genetic predisposition to cancer. For example, very commonly we use it for screening for Lynch syndrome, where you'll have mismatch repair gene protein encoding errors. So these people have endometrial and colon cancers, colorectal cancer risk. And of course, very another common screening which is done is for the breast and ovarian hereditary syndromes, where the BRCA1, BRCA2 mutations are reasonably common. They are they have a risk of developing breast cancers, and lifetime risk of developing breast cancers around 40 to 60%, depending on the mutation. So also it has implication follow-up. Patients who are detected to have these mutations, their follow-up and their regime is different from, their screening is different from a normal patient without the genetic disposition. Now, coming briefly to what are the major headings, they are going to be speakers with more expertise than me. I have been trying to understand this for the last 4-5 years. I have not understood completely. The basic headlines of a next generation sequencing technology includes isolation of enrichment of the neoplastic nucleic acid. This is done either from the cell-free DNA or from the tumor tissue from the formalin embedded paraffin embedded sample. You have to extract the DNA or the RNA from the sample. And library preparation, it entails the already pre-assigned probes or assays, which help in identifying replication and increasing the neoplastic alterations or the mutations. And of course, the sequencing by synthesis. Illumina platform is one of the commonest next-gen sequencing platforms that is using by synthesis or copy numbers. The pH sensing technology using ion torrent, Thermo Fisher, etc. These are the examples of certain platforms. And finally, bioinformatics. As I already mentioned, there are a lot of proprietary, a lot of the companies have their own proprietary softwares and their own proprietary data based on the previous, a lot of them, of course, take it from the Human Cancer Genome Project, which cost billions. That project where every cancer genome and the molecular this thing were all done step by step using Sanger sequencing. Project cost billion and almost 20 years. And right now the similar information, because they did that and we have a library of that information, you are able to use some software, you're able to use the bioinformatics to get the data. We are able to do it for less than equivalent of around 1 lakh rupees right now. The same information which took billions of dollars. Now, as I mentioned already, we have to integrate these genomic results which we get into report for a clinical decision and support to make a precision oncology a reality. So this includes a very important thing. As I mentioned, this data gets generated. What is this data? There will be a lot of mutations and there will be a lot of variants, which we don't know what is it. Some of them will be variants of unknown significance. There will be some variants without clinical utility. The very first thing would be to remove the variants without clinical utility. Second thing is the variants with clinical utility, classifying them. Are they significant? Are they insignificant, etc.? The tumor allele burden. There are certain genomic considerations to take in place to assign them as a variant of unknown significance or a variant of significance. Then, as I already mentioned, information management platform for incorporating these molecular genomic data into health records, so that it is an easy easy to interpret, easy to reproduce and give it to the patient format. And once this comes, a lot of time right now you have molecular tumor boards where there's the treating oncologist, especially in oncology, treating oncologist, radiation, medical, the surgical specialist, the molecular oncologist, the pathologist, where we sit and try to correlate the pathological, the clinical features, clinicopathological features along with this molecular features and determine the best possible management for the patient. Now this picture from an article by Noah et al. Should show you the entire cycle of next-gen sequencing, where you have the tissue sampling, you have the sequencing, you have the raw data which is developed, and then this raw data which is acquired is passed through the bioinformatics system. Each company has their own bioinformatics, and then you get an analysis pipeline where the evidence-based curation platform, variance is reviewed and then it is reported. This is where the bioinformatics play a very important role. Then it goes through a precision diagnostics and the report is generated. It comes into, ideally should come into electronic health record, where it helps both in diagnosis, prognosis, and also predictive value of the report. And of course, the MDTs, multidisciplinary tumor boards, where the oncologists, pathologists, surgeons, radiologists, and clinical care team curate and decide on the appropriate management for the patient. And in between also we need to reassess. We can take the samples and send. Coming to studies evaluating the feasibility and the clinical benefit of molecular profiling, there are various studies which are done. I feel a lot of them are important. These are done for any patients who have had, one of the trials which I am mentioning first is the IMPACT trial done in MD Anderson, where any patients, irrespective of the tumor type, with all advanced refractory disease, there were some 11 genes which were assessed, and basically they were not just assessed, they were also given specific, based on the reports, they were treated with whatever target or off-label target available. So it was found that there was a higher overall response rate and a progression-free survival. We don't have the overall survival, it's a progression-free survival seen compared to an unmatched therapy. The other two trials which had looked at all this, they showed there's a Predict trial, which again used MGS panels. And basically the endpoint or results is that a lot of patients had a 45% extended progression-free survival compared to 30% with patients with older therapy. The Shiva trial is one of the older trials. So there are various. Moscato trial is there, Shiva trial is there. All these have used comprehensive genome panel for all advanced refractory diseases of multiple subtypes, lung, breast, colon, etc. And patients have been treated with those targeted therapy based on the reports generated. A lot of them are also negative. I have to tell you, a lot of them are also negative trials, in the sense that overall survival was not proved in any of this trial. So that is why in a lot of the guidelines, next gen sequencing may not be appropriately used in all tumor types. Certain tumor types like lung, etc., it is advised. Melanoma, it is advised, not for others. Now, what are the obstacles for the implementing and precision oncology or precision medicine? One of the major issues is the limited predictive value of most of these tests, as I told you. There is a limited number, as I told you previously with the examples of the trials, that there are a lot of negative trials, and there's a limited number of examples where the genetic testing has led to a substantial gain in guiding the therapeutic recommendations for both healthy individuals and in some cases also patients, refractory patients. And the only advantage maybe in a healthy individual would be in risk estimation, disease, risk estimation, and lifestyle modifications based on that. Again, coming to lack of knowledge from a clinician side, a lot of the medical practitioners, this is not a problem with India alone. I feel it's a problem with majority of the oncologists anywhere in the world. They do not feel adequately prepared to provide the counseling for genetic testing. It is not enough to just order the genetic test. You really need to counsel them. When we talk to the patient, we talk to them about the implications of the test. Some of these reports may not, if you see them also, there's nothing actionable which may lead to, so you have to counsel them properly before ordering these tests. There is an inadequacy felt by a lot of us, and hence And also the number of counselors, genetic counselors, clinical geneticists are all lower in number, and then the even current demand, which is low right now. And soon, as the technology cost goes down, I think there'll be much more demand. We still have a shortage of these geneticists and genetic counselors. Currently, they are trying to incorporate personalized medicine into the current, teaching both undergraduate and postgraduate level. Precision medicine may expand outside of oncology. Currently, it is the most utilized by oncologists and hemato-oncologists, but it will expand. There is prenatal diagnosis and all play important part into it. And second thing is currently there's a little infrastructure in place to facilitate the education of clinicians also. Now, another issue is the inadequate informatic infrastructure. What I mean by that, there's a lot of data that is being generated. One, data at the testing level. At the same time, you'll get a lot of data, even the data that curated data which comes to a healthcare provider who has requested for the test originally. There's a lot of data and the information present. And right now, even though we have adopted electronic medical records in major hospitals and all that, a lot of us will require, substantial enhancement of capacity. For example, cloud capacity or data storage capacity, and thorough output needed to process anticipated, this genomic data, because it is so huge in number. And of course, issues which come to information provenance and patient privacy issue. Privacy issue remains a problem. I mean, we don't discuss it much in our country, but then a lot of the patients may not want this genetic reports because it passes through many hands, even outside. They may not want, this reports to pass through so many hands. There is an inconsistent standardization. I told you there are various companies and there is an inconsistent standardization, and there's oversight in the testing and the reporting process. Of course, the College of, I think CAP, there's a College of American Pathologists are trying to make some, and some molecular pathologists are trying to make some guidelines reporting NGS. And coming to reimbursement issue, yes, since these are not yet a standard of care, there'll be issue of, for example, if a patient based on an NGS, report is getting a drug which is expensive, or even a simple drug that cannot get covered by the insurance, stating that this is not a standard of care or this is not right now in the guidelines. And genetic discrimination is a major thing. I feel this again will come in play in patients who are insured. Detecting some variation. We really don't know the value, whether this will an oncogenic mutation or variation in a normal person. Will there be a discrimination when he goes for an insurance or when he goes to a workplace? We really don't know. So that is something we really need to think about when you think about precision medicine. Now there are also the societal issues and misconceptions. Acceptance of a genetically based treatment recommendation right now is low, even among physician groups. And there is a certain misconception that a genetic risk could result in an over medicalization of a society, where a healthy individual becomes preoccupied with the disease prevention based on that genomic profiling, or he undergoes unnecessary testing and procedures. In fact, there was a study of such individuals who underwent this comprehensive genomic profiling based on, this is not in India, this is a American this thing. That reassured people who had this issue that there was no evidence of increased anxiety in those particular patients compared to patients who are not tested. People who are not tested. I won't say patients. These are people who tested and detected some mutations. There was no increase in the anxiety. Again, genomic sequencing will identify a variety of high-risk alleles in normal individuals, and until we understand with the limited understanding of the risk concepts and the penetrance, whether it's a high penetrance, a low penetrance, a low risk, high risk allele, we could inappropriately influence even reproductive decisions. Patient with some particular mutation not understand. Person with some mutation, he or she may not wish to go ahead with the family due to so poor understanding of this alleles, etc. Yes, of course, there may be an adverse impact on patients with sensitive issues such as psychiatric disorders and behavior disorders, and the disability of learning of an individual. If an individual has increased risk of a particular condition where there's no treatment or prevention available, is a questionable thing. In fact, Huntington's disease, which has no particular treatment, more than 80% of at-risk individuals who have no symptoms, they chose not to pursue testing, because if it was positive, they felt that they would be more anxious about it. And that's the importance also of genetic counseling. When you counsel them, you have to tell them also the implication, especially high penetrance mutations, etc. You can find it in your siblings, you're going to find it in your children. So this affects the family dynamics by the disclosure or failure to disclose this genetic information, etc. So these are the issues we have with personalized medicine and the genetic information or the precision diagnostics we have right now. Just to complete the talk, I think in the current practice, for a certain patients only, we are able to give them this personalized oncology or precision oncology. One is the cost factor involved. There are a lot of, right now, there are a lot of both India-based company, and you have companies from abroad also. You have the foundation one, people who got the original data from the Greek study, that is the Human Cancer Genome Atlas, where they do this next-gen sequencing and give you a target. They give you the report based on their bioinformatics and their their genomist opinion. And it is usually used in setting of a disease where the standard of care is either very poor. In a lot of diseases like pancreas, etc., where even the standard of care, you don't expect a great survival, or it is used in a relapsed or a refractory setting where the treatment options are limited. And there's a cost issue. Right now, a lot of these tests are not covered by insurance, and a lot of times also some mutations, especially off-label indications, may not be covered by insurance. Now, labeled indication, for example, you detect a EGFR mutation in a patient with lung cancer, we are sending NGS 15 targeted panel for lung cancer. That is something we are doing very commonly. And you get a EGFR mutation, because that is part of the guidelines and the standard of care that is covered by most of the insurance or the reimbursable segment. With this, I would like to once again thank Dr. Chris for this opportunity to address all of you. Shall I stop sharing?
Yes, sir. Thank you so much. And I would agree when you say that a lot has to be still done in this field. But thank you for setting context, and we'll definitely, have more discussions around it. But for now, we have certain questions that I would ask you to please take it up. So my first question is from Dr. G.K. Agarwal, who says, what is the current status regarding use of blood tests to detect circulating cancer cells before clinical manifestations of malignancy set in?
Very good question. That is also something, as of now, the current recommendations from any of the major oncological organizations, let it be National Comprehensive Cancer Network, or let it be American Society, or even our Indian Medical Oncology, Pediatric Oncology Society, there is currently no role. One thing, circulating tumor cell, analysis of circulating tumor cell, there are 2-3 technologies as I discussed. One is looking for a germline mutation, that is an inborn mutation, germline mutation in normal people, or looking for the circulating tumor cells. Usually, when that is detectable in patient, most probably will have a radiologically or a clinically diagnosable disease. We have not found even though studies are ongoing as a screening tool, circulating tumor cells, it is expensive, impractical, and it is not yet a standard of care, maybe in the future.
Okay, sure. And regarding the ethics bit, I think you did talk about, but we have one question around. So, do you see any effect that the lack of health literacy or genetic literacy for obtaining informed consent?
Once again, very good question from whoever asked that the genetic. This is why I focused a little bit on the need for counseling. There is, I cannot just order a genetic test, especially one which has a genetic implication. A somatic test is easier to order. That is one we're looking for mutation, a particular thing. When you're ordering a genetic test, it has a lot of implications, both financially, both societally, psychologically, etc. And the implications passed down to generations, either laterally to the siblings or downwards to your offsprings, or even your parents if they are there. So definitely, you really need to spend time and counsel, make sure you understand it, and then go ahead with the testing. So that is where the genetic literacy, it is a duty of the physician to, or the caregiver to, counsel them. If we are not able to, most of the time, unfortunately, now practice due to especially in an institution type setting where you have a lot of patients coming in and the time is limited, we may not be able to do it properly. But then, ideally, they need a genetic, counseling.
Okay, sure. Again, another question about insurance companies. So do you think there's a possible discrimination that we see by insurance companies and employers?
Yes, that is a genuine fear among all the advocacy groups, among medical oncologists also, that there'll be a bias. One of the bias may be for a normal person. In fact, the bias may be for let's say patient with already cancer, he has it, and if these tests get accepted into a standard, guidelines, we'll be able to practice it more often. But let's say a normal person who has undergone a screening genomic profile and detects some, let us say, a BRCA mutation. So he or she, if it's a he has a risk of prostate cancer, he has a risk of male breast cancer, pancreas. It's a she, they are at the risk of, again, ovary, breast, and pancreas cancers, endometrial cancers also. So there is a very genuine fear that insurance companies can reject. It's a fear throughout the world, not just in India alone. Because we are seeing in our clinical practice for very flimsy reasons, even very solid, when we have solid evidence backing it, insurance may reject some clause which is gray area. So it's all legal speak to just confuse us and make us. So this definitely is a fear. I would be very, very about it. It needs to be. As a group, as both caregivers and doctors, it's our responsibility to address it. I think a lot of our forums have brought it up.
Correct.
But it is a genuine fear. There's no answer for that. It depends on the insurance policies.
Okay, sure. So I think concluding the session, I think so insufficient technology, limited knowledge, and also gaps in research are major obstacles, I think, what we see in adding precision medicine to the routine clinical care that we want to. So, sir, any closing remarks for our audience who are watching us here and would want to know more about precision medicine?
Yeah, so the precision medicine, in simple thing, you have the genomic data and curated to what can be applied to a patient properly. The trials, the reason I brought up the trials thing, these are trials to help, the trial designs are for precision medicine in mind. Precision medicine is going to be the future. There's no doubt. All these investigations are going to get cheaper day by day. As I already mentioned, the Cancer Genome Atlas used up more than $1 billion with the same test, same information right now, because they have done it. We'll be able to generate it, and $1 billion into it. We'll be able to generate it within 4 weeks at the cost of maybe 1 lakh or 2 lakhs maximum. And as time goes by, it will reduce, and we may be able to offer, from an oncologist point of view, we may be able to identify some high-risk mutations in patients who have, so predicting further prognostic markers. Also, in relapse refractory cases, it may give some off-label targets. That's what we're using it for right now. And the future, definitely, this is going to be the future. This is going to be the in thing.
Thank you so much, Dr. Haridas. I think it did make a lot of sense, and I think, as we discussed, we'll definitely plan another session, coming forward in the coming months, wherein we can talk about multidisciplinary approach, or we could talk about different aspects of super specialties working in precision medicine. So with this note, sir, thank you so much for joining us today and speaking to us on this pressing issue and a most, I think, leading ways in which we are treating cancer these days. So thank you so much and have a very good evening. Thank you.
Thank you. Bye.
Thank you to our dear audience who joined us today for the side session.